Welcome, everyone. Thank you for joining. We're going to give it a couple minutes and let some other people trickle in. We'll give it about one more minute and then we'll kick things off. Okay, we are at the top of the hour, so we are going to get started. Thank you, everyone, for joining tonight's webinar. We are going to be talking about an exciting new orthopedic enabling technology, augmented reality, and its role within total knee arthroplasty. My name is Josh Hagel. I'm the U.S. Vice President of Sales for Pixee Medical. Joining me is Dr. Safa Kassab, one of our super users in the U.S., located in Detroit, Michigan. Dr. Kassab is going to provide his clinical insight and experience. Before that, I wanted to provide an overview of the company Pixee Medical, as well as the technology overall. If there's any questions during this discussion, please put them in the chat. We also will have a Q&A session at the end of the presentations where we will unmute people so you'll raise your hand and we'll unmute you and you can ask a question live. Obviously, if there's any questions after the fact, we'll have all of our contact information up for display at the end, so you can reach out to myself, Dr. Kassab, or a member of my team. All right, so let's get started. First, I want to talk a little bit about Pixee Medical as a company. So we are 51 employees based 2 hours outside of Paris, France. We are clinically active doing cases in 19 countries around the world, and to date, we've done over 10,000 surgeries globally. So this next slide illustrates a U.S. map of cases that have been done in specific states around the U.S. On the right side, you'll see our org chart in the U.S. So I was the first U.S. employee. I also have 2 sales directors, Mike Branham leading the eastern half of the U.S. and then Brendan Baker leading the west. And then we have our clinical manager, Jerome Gergis, who travels throughout the U.S. to support cases and training. Next, I want to talk a little bit about Knee Plus as a technology. So the system consists of a set of smart glasses, as you can see here on the left, that attach to the Stryker helmet. So it's compatible with or without a helmet. This is an example with a helmet. So the glasses attach to the helmet and provide data based on the position of these QR codes that are attached to the small 12 by 12 instrument pan. So on the ends of the instruments itself, the position of those QR codes, the glasses track and provide the surgeon real-time feedback. So reusable instruments, and then these QR codes are essentially similar technology to if you scan a beer list at a restaurant, just a much more supercharged version of that. So distal femoral cut, tibial cut. On the distal femoral side, flexion extension, varus valgus. On the tibial side, posterior slope, varus valgus. We'll talk a little bit about our new software and what's coming, additional functionality that we're going to be displaying actually next week at AAOS. So some features and benefits, seamless integration. So it's very, very easy for surgeons and facilities to adopt, a very short learning curve. And I'll let Dr. Kassab speak later on his adoption and his onboarding. It does not take control out of the surgeon's hands, so works into really any existing workflow. It's a universal platform, so it's a totally open platform, compatible with any primary knee implant system. A personalized approach, so whether your surgeon is mechanical or kinematic or whatever your philosophy, your alignment philosophy is, we can help hit those targets. So we're telling you where you're going, not necessarily where you need to go. So it's obviously less invasive. So no IM rod in the femur, no IM rod in the tibia. There's no external arrays, so no reason for pins in the femur or no reason for pins in the tibia. There's no CT scan required. From an economic perspective, it's cost effective. So we are a simple pay per case model, no capital expense, no disposables. The facility, cuts us a PO for a certain amount of cases. We generate a QR code, send it to the facility. They flash that QR code in front of the glasses, and all of those cases are instantaneously downloaded onto the glasses. Every time the surgeon does a case, it deducts a case from the glasses. Simple and compact, as you saw in that last slide, just a small 12 by 12 instrument pan and then a set of smart glasses. So there's really no footprint in the OR, very ASC friendly, obviously, and then accurate and efficient. So as I mentioned earlier, we have a new software release coming up. Some big differences with the workflow. So one of the biggest is resection depth. So right now, the current version, you use a mechanical stylus to measure resection depth off the femur and the tibia. Our new version will have digital resection depth. So it's going to tell the surgeon how much you take off the medial and lateral side of the femur and the tibia in a digital format. The hip center registration. So Dr. Kassab will go through his workflow, but to find the center of rotation of the femoral head when establishing a mechanical axis on the femur, you have to cycle the hip with any robotic or navigation system. Right now it's 10 static points. It's going down to 5, so it's going to become even more efficient. The interaction with the software right now uses an accelerometer, so the surgeon tilts his or her head to the left or the right to advance the workflow and select certain options. You're going to be able to talk through the workflow with our new version, similar to talking to your iPhone. You'll just say, "Hey, Pixee," and then give it voice commands, and it will walk you through the whole workflow. So a very simple and streamlined workflow. And then compatibility with the new Stryker T7 helmet. Right now, we are compatible with the Flight. The Flight is being phased out, so we will be compatible with the new Stryker helmet. So that is all I have from an overview perspective. I'm going to let Dr. Kassab share his insights on the technology. So I'll let Dr. Kassab share his screen and take over.
Thanks, Josh. I appreciate that. I've always got to ask, you can see my screen, correct, Josh?
I can, yes.
Perfect. All right. Thank you all for joining. And I know all the different time zones. I appreciate it. As Josh says, I'm, I guess, a super user. I've done over 800 consecutive Pixee knees, and I'll go over that with you guys in the last 2 years. I'm also a consultant for MicroPort, which should not have any effect on this talk. But this talk is essentially taking our knees from good to great. At least in our case, we looked at it. And why do we need a knee plus? Why do we need any technology for our total knees? Most of the surgeons on the call understand that some of the studies say up to 20% of our patients aren't happy with their knee replacement. And if you do knee replacement, you'll understand that as well. And so it's felt to believe it's either due to poor execution or possibly the precision of the present way we do total knees. And so therefore, if we can find a technology or any kind of process that reduces our complication or cost, that would be beneficial. And so robotics kind of tried to fill or is trying to fill that void, right? This is an article out of the Journal of Arthroplasty done 2 years ago, almost 3 years ago in 2022. It's a great article because they matched manual instruments with robotic knees. 6 surgeons looked almost at 5,000 patients. And in brief, what they found out, and anyone who's used the robot understands, is that it takes a little longer to use a robot. And interestingly enough, they broke it down into the time it takes to set up the robot and break down the robot, and also the time and procedure. And you see the time in the procedure is only about 8 minutes longer, but it's 32 minutes in the setup and breakdown. Length of stay readmission was not much different, but the cost, and again, they took an interesting approach to the cost. They looked at the supply costs, which obviously is, again, is the drape, the pins, and so forth, but also the labor cost involved. And they found that the robotic cases cost about $3,000 more. And that didn't even include the preoperative imaging that's necessary in order to do the robotics. And so the augmented reality system kind of solves some of these problems. And this is the latest article on the Pixee augmented reality. This was in our Arthroplasty Today just about 3 months ago. This is from the Netherlands group, Dr. Van Overschleid. And they looked at the accuracy. They took 124 cases with two surgeons, two experienced surgeons. And they took 124 cases and looked at the accuracy at the lateral distal femoral, medial tibial angles, and so forth, and found that it's just as accurate as robots are within a degree, except for the posterior slope, which is kind of consistently greater in most all systems. The learning curves for these two surgeons, one surgeon was about 1 to 10 cases, the other one from 2 to 28 cases, and their times were about 10 to 14 minutes longer. And so again, they did a nice comparison of all the literature with regards to different robots and all the different cases that they had, and found that their cases were in line with the robotic cases. And so they felt like that the Pixee Knee Plus augmented reality system provided high accuracy and comparable to robotically assisted total knees. We started looking as to for a technology solution for our ASC. So most of us in America have some ownership in an ASC, and we weren't looking for technology just for the sake of technology. We wanted to find a technology that met our surgeons' needs, improved accuracy, eventually and ultimately improved our patients' outcomes and patient satisfaction, but we also didn't want to negatively affect our workflow or efficiency, particularly because we're in an ASC setting. We needed to be cost effective, and honestly, we also needed to be able to fit within our ASC and not really hinder our workflows. And so I contacted Sebastian Henry, who is the founder and president of Pixee, in 2021. I actually read an article in the Italian literature that was talking about this new augmented reality system. We had not even had FDA approval at that time. He told me that he'd get back to me after they had FDA approval. We continued to communicate. And in October, I did a virtual training. The engineer was in France. I kind of just watched him do a sawbones and said, yes, this looks good. They flew over in February of 2022 with one tray. We did 4 consecutive cases, and that was proof of concept for me, and we were all in. And so beginning in August of 22 is when we could get our trays and glasses, and we started using it and haven't stopped since. We've done consecutive cases since then. It's got to be over 800. We're probably closer to 900 cases consecutively since that time. We published our first 20 cases with 17. 3 were excluded because of trauma and some various other issues that excluded them. But this was kind of a case series that reported. And the reason we did this is we just wanted to kind of show that this is possible. And this was the first North American article or case series on this. So we looked at our first 17 cases. This is case 0 to 17. And this is the kind of stratification of our patients. You can see these are ASC patients, 30 BMI, ASA 2. My technique is a short-acting spinal, multimodal pain management, single shot blocks, adductor blocks done by anesthesia, no tourniquet, and we don't evert the patella. And I'm a mechanical alignment, I should say, a mechanical alignment. So we looked at our kind of angles. This was published last March, so a year ago to this month. And we looked at our angles as well. And similar to what they found in the Netherlands and all the other articles, that the Pixee augmented reality system is indeed very accurate, almost to degree accuracy. And again, postertibial slope was the only one that was slightly off, but that's kind of consistent across all the technologies. We looked at our times. We looked at our incision to cementing time, which was about 38 minutes. We compared the incision to closing time. These were, again, our first cases, and therefore we're, truly in our learning curve. And compared it to our traditional cases that we had done months before, and it was about 7 minutes longer. It was statistically significant, but clinically it was only about 7 minutes longer. And since then, we have significantly reduced our time. Since then, we've done, like I said, several hundred cases. And so we are presently studying and have IRB approval and crunching our numbers for 2 data sets here. We have a 2023 data set of 322 patients done at a single institution by a single surgeon, and then the same surgeon, same institution in 2022 without Pixee. We're going to start looking at it. We're looking at our times, our patient-reported outcomes, our complications, our morphine equivalents for these 2 groups of patients, and then the cost as well. This is raw data, has not been statistically kind of validated at this point, but this is kind of our patients for the 322 patients. These are hospital patients. The reason we have the hospital is because we're able to extract very granular data from their EHR as well as a quality initiative, which we belong to. So these are our patients, slightly bigger, ASA 3 patients. These are a little sicker patients, again, comparable to the patients we did in 2022. When we look at our times, since we've done these cases, we can see that our traditional patients are about 41 minutes, as reported earlier, but our augmented reality patients are now about 43 minutes. And so therefore almost equal. And again, we haven't looked at the statistical significance of this, but I'm sure it's not going to be statistically significant. Even if it is, it's not clinically significant. And start to stop. So this is kind of where you look at that setup and breakdown time. And again, it's about 5 minutes in total. And so therefore, as Josh said, with Pixee, there's really no setup time and there is no breakdown time. The system's extremely portable and efficient. This is our scatter plots of our patient-reported outcomes. These are Knee Society scores, and what you can see is this is the no change line. So at 10 to 14, I'm sorry, at 14 to 112 days, most patients are doing better than they were before surgery, but obviously as time goes on, they're doing better. And again, we're going to try to compare this to our non-augmented reality patients and see if there's truly a difference and see if this actually improves outcomes. This is, again, PROMIS scores that we're going to be looking at as well and see if there's any statistical significance between the 2 groups. And so jumping into how you do this, the clinical side of this, and that's what I'm going to cover. And so initially it starts by positioning a bone reference marker in the notch in the distal femur. As Josh said, everything is done within the wound. Didn't change my workflow and should not change anyone's workflow. These all just kind of work within the wound and nothing goes outside the wound. And so you put this initial marker along Whiteside's line and line it up in the intercondylar notch and pin it. This is kind of what it looks like. This is distal. So looking straight onto the distal femur here. This is from the side, having it up. Take the hip through a range of motion with a static marker on the outside. That's done sterilely. I'll show you that in a minute. And then obtain the mechanical axis, the true mechanical axis of the femur. So this is kind of what that looks like. This is being held on a holder here, the static marker. Now we just do a Mayo stand and then take the hip through a range of motion. So this is a video, and I apologize if it goes a little slow. I know with Teams it tends to buffer. This is kind of with a timer in the corner. So this is, oops, let's try that again. This is in real time. It's not been edited. This is a case I'll show in a minute. This was a patellofemoral revision, actually, that pinning the marker in the distal femur. What you're seeing on the top right screen, I'm seeing in my glasses in front of me. It's able to project. And so you can see it's going to be just below 30 seconds before we obtain our, there we go, our hip center. And we'll be able to obtain all 10 points in about 26 seconds. So as we obtain the points, the yellow progression there just lets you know you've registered a point, and it just keeps going. You don't need to take it in a circular motion. You can take the hip through any type of range of motion as long as these points are individual and unique. And if it's not, it tells you. And at that point, that's it. That's the whole hip center. So once the hip center is obtained, you put the cutting and alignment jig over that initial marker. And like Josh said, you can dial in varus valgus and flexion extension and make your cut. And so this is, again, what it looks like. This is the initial marker. It's hard to tell here because of all the metal. And then this piece slides over that. So this is the cutting block is here, right here. And then I'm here dialing in the numbers. And this is kind of what it looks like in my glasses and projecting onto the screen. This blue line is the mechanical axis. The center point is the center point of this marker. And then there's another point you can't see here. I'll show it in a minute that goes into the hip center and then giving you kind of numbers that you can dial in. I think one of the truly greatest advantages of this system, and probably some of the other technologies, is that you can actually validate your cut. And what that means is not just checking if your cut's level, like we could with manual instruments, but you can actually check and see how close you were to your target. And that's something that was impossible to do, especially on the distal femur. Maybe on the tibia, you can do a drop rod or something, but there's really nothing to kind of validate how close you got to what you thought you were going to do with your cutting block. And with this, you take this validation marker, place it on the distal femur, and then this marker goes back onto the cutting block. And what you end up with, so this is that validation marker on the distal femur here. This is onto the cutting block. And what you end up with is this kind of picture. So it shows you that, yes, you're indeed hit your target and or within a degree of this target in the flexion extension. This is kind of showing validation. And again, I apologize if this video doesn't play normally, we'll see. But this is a case we just did last week and just had our rep kind of, excuse me, film it. So we see we're in one of valgus, we're in one of flexion, not exactly where I want to be. So I've gotten to the point now where I know what I need to do and what side I need to cut. And so this is tilting my head to go back. As Josh said, you're going to have voice controls and hopefully very soon. So this is taking the saw back, making a cut along the medial side to get rid of some of that valgus, and it's just running the saw through the block because I know that block is properly pinned in position. Putting the markers back on and testing again. And you can see this initial test gives me about 1 of varus at this point. I tend to check twice, and so when we check it again, it gives me exactly what I need, the numbers that I need. And so, and if it didn't, I would make my cut again. If need be. But again, that validation step kind of gives you that confirmation you need in order to know that your cut is exactly where you thought it was going to be. Sorry. Next, same instruments. Once that distal femur is cut, then you size the femur and then do your 4-in-1 cutting block. Same instruments, flip it over and put this into the tibial spine. Line it up with the tibial tubercle and pin it once again. Collect 2 data points at this point, a lateral malleolus and a medial malleolus, and obtain, this is the lateral side, this is the medial side, this is the initial marker. And then you get the mechanical axis of the tibia. Same thing, same cutting block, same jigs. You just flip them over, attach them here, and now you can control varus valgus and the posterior slope of the tibia. And again, this is what it looks like. So this is, again, just to orient you, this is proximal here. So this is attached to the tibial spine, this marker here. This is the cutting block right here, and this is the alignment jig. This is looking straight on, and this is me dialing it in, and this is kind of what it looks like. So this is the point, again, at the tibial spine. These are the lateral and medial malleoli. This is the center point, and this is the mechanical axis of the tibia, and this is the numbers I'm dialing in, and this is the HKA angle that provides you. Again, once the cut is made, that validation marker works on the proximal tibia just like it did on the femur. Again, validating your cut to make sure that you indeed cut what you said you would. And this is kind of what you see here. So this is me putting the validation marker on the proximal tibia. This is the cutting block pinned on the proximal tibia. And you can see you get, the numbers that you hopefully think. This is a video of an entire case, but obviously it's edited. It's only about a minute or so, and just showing the key steps. So again, this is collecting the data points once again. This is at our surgery center. The room's not huge, and again, very easy to do this, right? And so once that's collected, the alignment jig and the cutting block will be placed onto that point. And again, what you'll see here is it starts out there and I'm dialing it into where I want it. And so get it to where you want it. This is, again, that mechanical axis of the femur. It's the true mechanical axis of the femur. And that cutting block is being set to that, right? Once I like that, I validate that, make my cut, and then I'm able to validate. This is, again, that validation marker that I'm putting onto the distal femur there. And again, able to check it and confirm our accuracy. This is collecting the lateral malleolus, collecting the medial malleolus. This takes a whole 5 or 6 seconds to do, and you're in. And there's your tibial alignment. And this is obviously projected. It's augmented reality. This is all projected onto the bone. And so you're able to follow along through your glasses. And this is kind of what you end up with, right? So you can see on this cut, this is after validating, we're about 181 degrees. and our slope is dead on. And so I know in our hands, we've never had this kind of accuracy, and I've done these for 25 years. And so just to go over some cases, and like I said, and when I say consecutive cases, I mean consecutive cases. We don't cherry pick. I mean, I'm proud to say that I've not done an instrumented knee in almost 2.5 years. This is a bad arthritic knee. We've got some that are not as bad, and we've got some that are much worse that we've been able to use Pixee with. And again, you can see them 179 degrees of varus here after dialing in our slope and so forth. And obviously, they're unique cases. By no means is it just for unique cases. You can use this in all cases, but it comes in very handy in cases like this, right? A terribly valgus knee, a distal, a femoral nail in place. This is the actual case where we pinned this distal marker. And honestly, would have never known there was a nail there when doing this case. This is that patellofemoral case that I was talking about that we showed the hip center on. Again, easy revision in the sense of just a patellofemoral, but I don't want to put an IM rod up this femur and kind of have blow through the front of the femur for any reason. And then again, doing that this way and using Pixee on that. We do use it on simple revisions. We don't use it on full out revisions. And so why Knee Plus for us? It met and exceeded our needs in our surgery center as well as our hospital setting. It's accurate and reproducible. There's no preoperative imaging needed. It's easy. It's a minimal learning curve. You don't need to change your workflow like Josh said. It really works with whatever workflow that you have. It works within the wound. It's scalable. There's really no footprint to it whatsoever. It's completely portable. There are no space constraints, especially in an ASC setting. Affordable. There are no disposable costs, minimal new instruments, and it's an easy ROI for the institutions to kind of buy into. And it's ahead of the curve. It's innovative. It's novel. It offers our patients the latest technology. Our patients deserve that, right? To get the best chance of succeeding in their total knee. It gives you a competitive advantage as a surgeon and even some of the distributors. It definitely differentiates you. I know when we first did this, I didn't do this to be different from anyone else. We really were just looking for a technology, but we've been on the news a couple times. And honestly, it's been a really huge kind of a growth factor for our practice. There's also the platform, right? So as Josh said, there are improvements that are just, around the corner with regards to digital resection. There are further improvements that are going to get made. This is a platform that's going to continue to grow and kind of continue to innovate. And the earlier you kind of learn this, the easier it's going to be to kind of grow with it. And honestly, our patients just deserve the best. I do think that Pixee has taken our knees from good to great. And our patients are doing well. It's anecdotal. And again, we're hopefully going to show that in our literature and when we do our publication. But our patients have never been happier since we've done this. I appreciate your time. I appreciate everybody coming on board, listening to this. And again, I'm going to stick around, obviously, for as long as I have to answer any questions. So I'll stop sharing, Josh. Josh, you're muted, I think.
Thank you, Dr. Kassab. Can you see my screen?
Yep.
Perfect. So we're going to open it up for questions. Please feel free to raise your hand and Lise will unmute you and you could ask your question live. If there are no questions,
I think there's one, Josh. I think there's a question.
Perfect, Tom. Please, can we unmute Tom? And Dr. Duke?
It's unmute.
Okay.
You can both
Tom.
activate your microphone if you want.
How about now?
Yep, we can hear you, Tom.
The doctor, the pins that you're pinning into the intercondylar notch,
Yeah.
you prefer a headed pin for that or a smooth pin?
No, headed pins. And so the reason is you want to really sink that down. So all these markers kind of, I always say hand off to each other, right? They kind of, one marker kind of reads to the other marker. So you want these as secure as possible. There are 3 holes, 2 cross pins, and then a single pin that goes straight in. I use kind of a headed pin or a stop pin, and just to make sure it's secure. And it's my softer bone, I'll use all 3 pins. Most times just 2.
Dr. Kassab, thank you for your presentation. Question for you or Josh. Do you know how long it will take or predict for the FDA to approve the next generation of software?
We are very close. So it's pending approval. We're hoping any day now.
So maybe able to show it at the Academy or no? Josh?
We are showing it at Academy.
Perfect. Thank you.
Yeah. Yep. Any other questions? Okay, well, if there are no other questions, I want to thank everyone for joining us tonight. This is my contact info. Please feel free to get in touch with me anytime. We will be at AAOS, as I mentioned, next week for the whole week. So we'll be doing Sawbones demos, giving people a peek at the new software. So please feel free to stop by. Again, really appreciate everyone's time tonight, and I hope everyone has a great evening.
Thank you all.
Thank you.
Thank you very much. Have a very good evening.